The first that I'd like to mention is free membership for residents as well as fellows. So I encourage all the younger members of our AIPNA network to log into ipna.net and become members. It does not cost you anything, but you'll be in touch with the more established members of the profession. We all who've been here for 30 plus years as pathologists want to do our best to see that you progress on this career path in pathology. And any questions that you may have, feel free to ask any of our executive committee members. We have several groups. Many of us who are in the executive committee of AIPNA are also members of the Bright Pathologist group. And we do try to understand your concerns about visa issues. We want to join people who want J1 waivers with pathologists who have J1 waiver jobs. And we've done that successfully right here at CAP. Also, there is a new initiative that is open to our AIPNA members and AIPNA pathologists in India. Anyone with an MD in pathology in India who wants to do a Surge Path fellowship here, we could join you to and connect you with members of AIPNA who have such one-year Surge Path fellowships in the US. So do get in touch with me. My email address is on the AIPNA website. Do get in touch with Dr. Bakul Dalal, who's also on the AIPNA website. We have many offerings in India as well as at US meetings. This AIPNA CME at CAP would not have been possible with the voluntary efforts of the speakers here today and our moderator. A few words about our moderator. Dr. Vijaya Reddy has been a lifelong member of AIPNA and a big supporter. She's the chair at Rush University here in Chicago. She's a dermatopathologist. And when I asked her, you're in Chicago, will you be the moderator? She did not hesitate. And she'll tell you about our speakers and the other flow of the meeting. To those of you who are here in person, please be aware that it is a meeting where serious presentations are being given on very timely topics by experts in the field, and we want it to be as silent as possible. This meeting is being recorded, and all the presentations will also be available on our website, ipna.net. The next AIPNA INT CME is going to be in Chandigarh, February 9, 10th, 11th. Many of you in the US who may not be speakers, I am not, but I still attend the AIPNA CMEs in India as a delegate. I tell you, the registration fee is much, much reasonable than meetings in the US, and it is so much fun. There's, of course, great food and hospitality. And most importantly, you can join hands with all our colleagues in India. And it's just, what shall I say? Every time I go and participate in these CMEs, I come back all cheerful. It feeds my soul and my spirit. The trips in India to be with our pathology colleagues back home. Many of us got our education in India. Our hearts are in India. And so this is a great way of sort of being back in that milieu with our professors, the very pathologists who made us who we are. And the meeting at PGI Chandigarh is going to be, a lot of PGI alumni will be speakers there. And it is that connection that we foster. So those of you who have immigrated and become residents in pathology here, don't feel that, oh, will I have this connection 30 years down, 40 years down? Through IPNA, you will. So I really, really encourage all of you to become partners and members of IPNA, and it's a volunteer organization. We want the younger folks to take over now. So please let us know your interests. Please uh, uh, join, volunteer, tell us which committee you want to be on. To those younger professionals, new in academics, IPNA wants you as speakers at our CAP meeting. I am the organizer, so please let me know your interests. If you're interested in being a speaker, we will consider you, and maybe next year, today you're in the audience, but next year you'll be one of the speakers. So don't hesitate to come and talk to me, send me an email, and again, for CAP'24 will be in Las Vegas, a fun city. So we are already looking for speakers for that meeting, and there'll be 3 presentations offered. Unfortunately, it's very early in the morning, a breakfast meeting, but what happens is these are being recorded, and the talks will be available on ipna.net. Again, our web address is ipna.net, and everyone who's a fellow and a resident or applying to be a resident, you can join for free, no charge for membership. Those who are established members, we ask for donations. IPNA is a 501c3 organization. We have many, many, many initiatives, and we want to expand our footprint. So we want you to become a lifelong member. We have a 10-year membership for $600. So I strongly advocate for it. Again, go to ipna.net, renew your membership. It's through Ziffy. Immediately you'll get a receipt. If you make a donation, we are a registered 501c3 organization, and you'll get a receipt for your income tax. So we are registered 501c3. We have many, many, though I may be the face that you see most commonly with IPNA. Believe me, it's not me. There is a team working on new initiatives. Dr. Jain at Yale wants to start a 2-day subspecialty conference for IPNA members at nice resorts so that we can be together. He wants to start Diwali events, local chapters. So we have many, many new people who want to do great things, want to give back. And so we are hoping that you will renew your membership, $100 annually. 10-year membership is $600, a big discount. Residence fellows, people who are applying for residencies, again, it's free. Our IPNA newsletter comes out 3 to 4 times a year. You hear about events. You can contribute to IPNA. We also support all our members in all their dreams, initiatives, drives. I'll share a few with you. First and foremost, at CAP'23, Bharti Zaveri, who everyone knows in India and here, got the Pathologist of the Year award. So big congratulations from IPNA. We also want to let you know that Ritu Nair, who's again from Chicago, vice chair at Northwestern, is running for the Board of Governors position at CAP. And this is a shout out to everyone. Please encourage everyone, all your colleagues, to vote for her. She's wonderful. She's done so much in the world of cytology, gotten so many awards, and also for CAP and the American Board of Pathology. So she's running for Board of Governors. Of course, we'll advertise her through our newsletters, but there is nothing like word of mouth. So I ask each and everyone to support Ritu Nair in her bid for governorship. A recent article in the archives showed that amongst the residents who are coming into pathology in 2023, 2024, 47% are international medical graduates. And I'm very, very proud to say that in such a competitive field, 22% are from Indian medical schools. So if we are giving so much and making the pathology field here vibrant, we also want to be recognized. We also want to be big participants in CAP, and running for a Board of Governor is showing that participation. I ask that many of you please and do join AIPNA, do join its activities, and our meeting is going to start now at 6:30. I think we are almost there. So again, thank you, Dr. Reddy, for agreeing to be a moderator, and I'll let you take over now. Thank you.
Good morning, everyone. Thank you all for being here, both in person and virtually. And Megha, thank you very much for all that introduction. And nobody can say no to Megha. Everyone knows that. So she asks somebody for something, they say yes. And that includes voting and funding, donations, talks, everything. So thank you very much for being such an integral part of AIPNA from the start to now. And I know you'll be doing greater things going forward. So today's session is titled Memorable Cases I Have Seen. And we have three really excellent presenters here. And I don't need to say too much because I'm a dermatopathologist. Anything I say might be misconstrued. So I will start with the first presenter, Dr. Pense. Avani Pense is Associate Professor of Pathology and Director of Surgical Pathology Fellowship, and she's involved in GI, liver, GU, and cytopathology at Duke University Health System. And she will be talking about memorable turbinates, not your simple urothelial carcinoma. Thank you so much. I could say a lot more about you, but I would rather hear about your cases, so come on over.
Okay, good morning, everybody, and thank you so much, Dr. Joshi and Dr. Reddy and Dr. Lagu. I see him in the audience for the opportunity, and I know it's early, but welcome to everybody who is here in person as well as virtually. So you have probably guessed from my topic that I am not going to talk about a case of urothelial carcinoma, but in the process of talking about this case, I am going to talk a lot about urothelial carcinoma because that's kind of like the big elephant in the room situation here. So just jumping straight into my case, this was a very typical story. Patient presented with hematuria, and as it happens, is it okay? Okay. And as it happens with that situation, the next steps were imaging and cystoscopy. Cystoscopy showed lesions in the urinary bladder that were nodular, and the impression based on the two was that of urothelial carcinoma. Based on that, the patient underwent a transurethral resection of the bladder tumor as a diagnostic as well as therapeutic procedure. And here is the first low power image, H&E low power image, which shows a lot of tumor. The tumor seems to be going deeper into the wall of the urinary bladder. And at this power, the architecture can be best described as nested. At a slightly higher power, we can see in the picture on the left here that there are a couple of islands where we can see well-developed muscle fibers. So there is involvement of the muscularis propria. The tumor appears to be surrounding the muscularis propria. And in the photo on the right, we can see a little bit of a higher power view, which gives us the cytologic understanding of these tumor cells, as well as some foci that are showing these scattered areas of necrosis. On a higher power, we see that there is a little bit of pleomorphism, not too much, but we do see some variation in the nuclear size here. And the mitotic activity is pretty brisk. And it wasn't throughout the tumor, but at least in some parts of the tumor, mitoses were not difficult to find. So in this field, we have at least 4 that I have highlighted here. So I am not going to put anybody on the spot here and ask them to give me a diagnosis just yet. I'm just going to tell you what was going on in my head at this point. At this point, I'm thinking, urothelial carcinoma, muscularis propria invasion, nuclei are enlarged, they are rounded, but they're not that pleomorphic. Mitotic activity is one thing that we look for in urothelial carcinoma to make a differentiation between high grade versus low grade. That was easy to find. So thinking about that still, but in a vast majority of situations, this would be the correct diagnosis. However, in this situation, I felt like my brain is misleading me because there were certain things about this tumor that didn't quite fit in cleanly with that diagnosis. So thankfully, my eyes didn't completely surrender to my brain, and that kept me out of trouble. So let's look at a few more images of this lesion. So here I'm showing you another low power image where we can see that the tumor does not appear to have a great connection with the surface urothelium. And this was a big specimen, 20-some slides of TURBT. I'm looking through them to find a connection with the urothelium. I don't see it. The second thing that I do not see is I do not see an in situ component, whether it's papillary or flat UCIS. I am having trouble. I find some reactive atypical areas, but I don't see anything that is, yes, this is UCIS. So for the trainees in the room or virtually, I would definitely urge you to get into a habit of looking for an in situ component in your cancer cases, because that kept me out of trouble in this case, but in general, that's a good habit to follow, and it'll keep you out of trouble in many of your cases. The next thing that I will highlight about this tumor is that it appears to be a little bit deeper into the wall of the urinary bladder, not mucosal based. It has well-defined borders, it appears nested, and I'm not seeing a great desmoplastic reaction in the context of the adjacent tissue. And then I'm looking around, scouring around for more clues, and I land on this area, which on the left, it looks like, oh, is there some crush artifact here? The next thought that pops into my mind is, maybe there is a neuroendocrine component here, and it looks like a small cell carcinoma at low power. At high power, we do see fairly high nuclear to cytoplasmic ratio. The nuclei are hyperchromatic. They appear to be molding with their neighbors. But then the one thing that I look for in small cell carcinomas is that single individual cell apoptosis, and I didn't see that. So this was a little bit odd. So now I'm thinking, oh, maybe this is just an artifact. But if you look at the piece that looks on low power, kind of like small cell, the center of it at least is pretty intact. It's quite free from cautery. So I have some ideas, and I'll share some of them with you. The first one is very simple. That's just it. I'm like, oh, this was supposed to be my easy case, and now this has become a thing. The second thing in my mind was, I better prove this to be a high-grade urothelial carcinoma by using some other tools that are in my arsenal, because this may not be a high-grade urothelial carcinoma. And the reason I'm saying that is usually when you see that small cell component in the neuroendocrine in urothelial carcinomas, that occurs in the background of a very high-grade pleomorphic appearing tumor. And in this situation, although there was some pleomorphism, it wasn't crazy. I wasn't seeing like crazy nucleoli, bizarre big nuclei. So I decided to myself that I better do something, show that this is a high-grade urothelial carcinoma. So in terms of IHC, the commonest differential in this situation is usually high-grade prostatic carcinoma. I did not tell you earlier, but this was a female patient. So that possibility was somewhat low on my differential diagnosis. So just so you don't think that I'm all on top of things all the time, I'll throw the other random thoughts that also crossed my mind. Maybe I also thought about what's for dinner tonight. But coming back to the case, started out with simple things, right? First order of business is this urothelial carcinoma. I get a P'63 and a GATA3, two very common IHC stains that we do. P'63 is completely negative. At this point, I'm like, GATA3 is also negative, at least in the quote unquote small cell component. But then when I looked around in other parts of the tumor, I do see some reactivity for GATA3. It's not strong and diffuse, but it's definitely patchy. And I want you to hold on to this particular IHC marker. So at this point, for a car and a trip to Hawaii, does anybody want to venture a diagnosis here? Okay, no takers. And I'm glad because I had not cleared that car and trip to Hawaii with the organizers. So thank you for that. So we will look at some other things. And I don't know what is on your wish list in terms of IHC at this point, but I got neuroendocrine markers on this tumor. Synaptophysin is diffusely positive. I chose this image because the central part of the quote-unquote neuroendocrine small cell area and the other parts where the tumor showed its usual epithelioid morphology, both are staining for synaptophysin. Same thing appears to be happening with chromogranin. Chromogranin is a little bit patchy, but some areas have that dot-like staining. Some areas just have outright diffuse staining. So yes, it has some neuroendocrine reactivity. What made this case clear is the workhorse stain for surgical pathology. And this is a pancytokeratin stain. So at Duke, the cocktail for pancytokeratin is A1A3, CAM'5.2, and MNF116. And this was the moment of clarity, because in the middle, the part that is staining positive for pan-CK is the native urothelium. And we know that the stain has worked. There is nothing wrong. On either side of it, I don't know how it's projecting in the room, but on either side of it is the tumor, and the tumor is completely negative. So at this point, if somebody wants to venture a diagnosis, or I'll just share it, my moment of clarity, this turns out to be a paraganglioma. And I think the thing that this case taught me is that having an awareness of a paraganglioma, that it's actually a thing that can happen in the urinary bladder, that's the thing that solved this case for me. I will be completely honest, it was not the first thing that I was considering, and I'm glad that my eyes didn't give up, and eventually I kind of stumbled onto this diagnosis. But the important thing to remember here is overwhelmingly, the first thing on your differential is going to be urothelial carcinoma. And those, especially the ones that are nested in appearance, as well as those that have solid growth pattern, can perfectly mimic a paraganglioma, unless you are picking up these subtle clues. So in terms of what helped, right? So let's do a little recap of our case. So we had a lot of tumor. The tumor was based in a subepithelial location. It did not have a good connection with the surface urothelium. I could not find a UCIS component. Once I started seeing the quote-unquote neuroendocrine, high-grade neuroendocrine component, great, it could have been a urothelial carcinoma with neuroendocrine differentiation. But again, those usually arise in high-grade urothelial carcinomas. I wasn't seeing a very pleomorphic high-grade component. The tumor nuclei are bland, the pleomorphism is very limited. I didn't see nucleoli. So ultimately, it comes down to thinking about the alternatives, which in this case was a paraganglioma, as well as you need a good IHC support to prove your point. So a little bit about paragangliomas, because we don't typically think of them in the setting of urinary bladder. So these are known by the name of extraadrenal pheochromocytomas, and that is a good name because it helps you, the nomenclature helps you understand the pathophysiology of these tumors. So these are very rarely seen in the bladder. They are reported to be occurring at a frequency of less than 0.1%. So this will probably be the only case that I will diagnose in this site as paraganglioma for the rest of my career. So I'm safe now. Now that I've said that, another one is going to come to my desk very soon. So the age range is pretty wide. Patients tend to be in their 40s or 50s. So the average age tends to be a little bit younger than your typical high-grade urothelial carcinoma patient. And slight male predominance, but not really. In this instance, my patient was a female patient. There is a strong hereditary component to these tumors. They can occur because of germline mutations in several genes, and the SDH gene family is the most predominant ones, with SDHB mutations being the commonest. So in that situation, it is now recommended that since these tumors are so rare and significant minority of them have a genetic component, immunohistochemistry for SDHB is recommended because loss of SDHB happens in all the tumors that are being driven by mutations in SDH family of genes. So in my instance, we didn't do that at the time the case was worked up because we just didn't have any of the relevant history. There was no suspicion for paraganglioma, but that's just something that now is recommended in the workup of these cases. The patients with SDHB mutations sometimes present with other SDHB-related tumors, such as renal cell carcinomas, gastrointestinal stromal tumors. So those can also be clues to this being something different. Think about something out of the box. The clinical presentation, many patients, like my patient, they just simply present with hematuria. They do not have the typical symptoms that we think of when we think of pheochromocytoma. But textbook presentation would be that of a patient that has, so quote-unquote, micturition attack. So during urination, they will feel this sense of anxiety, like sweating, hypertensive emergencies. And if the clinical suspicion works out and if labs are drawn, which in my case were not drawn, there would be an elevation in serum or urine catecholamine levels. Most of these cases tend to be benign, and I'm putting benign in quotes because I have more information about how these tumors are now handled. And usually in those instances, treatment with complete surgical excision is sufficient for these patients. In terms of histopathology, I mentioned already that these tumors arise anywhere in the urinary bladder in the subepithelial parts. So these are not mucosal based. Obviously, they're not arising from the urothelium. They tend to have this Zell-Ballen architecture that we learn about in medical school. It's stuck in my brain, which is large polygonal cells that are arranged in these vague circular clusters separated by very thin fibrovascular stroma. The typical description is that the sustentacular cells that are in these arcs of stroma stain with S100. But that doesn't always happen, and it did not happen in my case. So I did order S100, it did not highlight that sustentacular pattern. And that's okay as long as everything else fits with that diagnosis. Many cases will have this diffuse nested growth pattern. So we do see a vague stromal pattern, but it's not the classic. Some cases also are sclerotic pattern of growth with hyalinized collagen fibers going through, separating the tumor cells, and they mimic the infiltrative growth pattern of urothelial carcinoma even better. Luckily, that did not happen in my case. And then cytologically, the neoplastic cells tend to be round, polygonal. They have a lot of eosinophilic granular cytoplasm. They can have clear cytoplasm, which can pose its own problems with differential diagnosis. The nuclei tend to be bland. They have vesicular chromatin. They don't have prominent nucleoli. So the nuclear description, I would make it akin to a neuroendocrine tumor. In terms of what these things stain for on IHC, We already discussed S100 in the sustentacular pattern of staining. GATA3 is highlighted here because that is a major pitfall. If you throw a GATA3 and say, yes, this is urothelial carcinoma, you're going to get yourself in trouble because both these entities are known to stain for GATA3. And in general, my impression about GATA3 is I'm just losing faith in it the more I grow in experience. So for the trainees, again, have a panel, have your positives as well as negatives. That way you can make a confident diagnosis. Chromogranin is considered the essential protein for paragangliomas, so it has to be positive. It is one of the more specific of the neuroendocrine markers in this situation. And if chromogranin is negative, in theory, you can rule out a paraganglioma. The other two stains that we do not have at Duke, and I doubt a lot of people have them, are tyrosine hydroxylase and dopamine beta hydroxylase. They tend to be positive in catecholamine producing tumors, and then DBH is positive in non-producing tumors as well. But we don't have those. I didn't do them because P63 and pancytokeratin negativity kind of sealed the deal in this instance. So apparent from the way that I presented this case that the pretest probability of having a urothelial carcinoma in this instant was so high that I put that in my top of my differential diagnosis for this context where we are in the urinary bladder. But otherwise, I would feel that well-differentiated neuroendocrine tumors are the biggest differential diagnosis here in terms of morphology. And after I had this case in the urinary bladder, a few months later, we had a case of a paraganglioma in peripancreatic tissue. So the tumor presented as a neuroendocrine tumor of the pancreas. It was underwent an FNA, was called a neuroendocrine tumor, and then on resection, somebody felt like something is odd, threw a cytokeratin on it, which was completely negative. It happens. I won't necessarily call it a mistake. The other things in the discussion of a differential diagnosis are melanoma. Of course, anytime you think of epithelioid stains, again, the S100 positivity will come into play. But the pattern of S100 staining is different in these two entities. Melanomas usually tend to have a strong and diffuse pattern of S100 staining, and then the other markers listed there will also help you separate the two. By morphology alone, melanomas tend to be way more pleomorphic than a typical paraganglioma, and they have prominent nucleoli. So that should also be a clue even before you come to the IHC comparison situation. I mentioned prostatic adenocarcinoma. They also tend to have rounded nuclei. In this instance, you will again be helped with prominent nucleoli that we all tend to associate with prostate cancers. And then the last two are relatively rare, but I'm going to throw in the renal cell carcinoma here because sometimes paragangliomas can have clear cytoplasm, and then you're left wondering, oh, is this a clear cell renal cell carcinoma metastasizing from somewhere, depending on where you find your paraganglioma. And alveolar soft part sarcoma, I'm not a soft tissue pathologist, but I do know that they show TLE1, TFE3 mutations, and that can be used, and hopefully there will be some clinical clues that will help you along in terms of sorting out that differential diagnosis. So I said hold on for the benign aspect of these tumors. So according to the WHO 2017 Blue Book, all of these tumors, even the previously labeled as benign tumors, are known to have some metastatic potential, and they're all assigned malignant tumors in the ICD codes now. So the previous distinction between the benign and malignant paraganglioma categories is now eliminated in favor of this risk stratification approach. So the grading of adrenal pheochromocytoma and paraganglioma, that's the title of that chart. It's a little short, it's a little small font, but in short stands for GAPP, is a grading scheme that is relatively new that classifies these tumors based on their risk. The grading scheme has 6 criteria, which includes histological pattern, cellularity, presence or absence of comedonecrosis, vascular or capsular invasion, Ki-67 labeling index, and catecholamine type. So the maximum score you can get in this grading is 10. And as you can see here, the tumors that get a score of 7 to 10 have a high metastatic rate, a fairly low 5-year survival rate, and they are deemed high risk. But even the ones that get put into the well-differentiated category with a very low metastatic rate still have some metastatic potential. So it's important to keep that in mind in terms of what sort of follow-up you want to design for these patients. And this classification that is based on this morphologic criteria determining the risk of the tumor has actually been shown to correlate well with the risk assessment that is determined based on the mutational analysis of these tumors. So morphology, molecular going kind of hand in hand. So we'll come back to my case. So if we apply the GAPP scoring criteria to our case, then the histologic pattern was that of larger and irregular nests. So that got us a score of 1. The high cellularity and presence of comedonecrosis each got us 2 points. There was vascular invasion present. I didn't have it in the picture. We couldn't really assess for capsular invasion because of the nature of TURBT specimens. They become all fragmented. But vascular invasion was enough to get us that 1 score. And the Ki-67 labeling index in this tumor tended to be close to 20% by manual evaluation. And that brings back to that quote unquote small cell component where the Ki-67 was similarly low, and it did not approach anywhere close to the high rate that we see in a small cell carcinoma. So we got a total score of 8. We did not have the catecholamine data in hand because, like I said, that was not clinically suspected in this patient. But even without that, the patient had a total score of 8, so we classified it as one of the high-risk tumors. And not unexpectedly, but the patient has multiple lung nodules as well as bone involvement by paraganglioma. So after the initial surgical resection, she went through a couple of rounds of chemotherapy, and now she's on a phase 3 experimental clinical trial that is being basically run by experts in the neuroendocrine tumor group at Duke. So with that, I just want to acknowledge some of the people here. Dr. Lagu is here. Thank you for the opportunity. And AIPNA and the rest of the people in this picture are the GU pathology group at Duke. We have decades of experience in this group and a lot of kindness, and we show cases, and even the senior people bring cases. And there is a lot of laughter in this room for some reason, makes people jealous when they go down the hallway. What are you guys doing? The other reason to put this picture here is also I'm going to shamelessly put in a plug for the Duke Surgical Pathology Fellowship. If there are any trainees in this room, or if you have trainees that are interested, call me, give me a call. I have my contact information on the Duke website, but it's my first name dot last name at duke.edu. So it's easy. That's all I have. If there are any questions, I'm happy to take a shot at answering them.
Thank you so much. And that definitely is a memorable case even for me. And I invite anybody with any questions, please come to the microphone and ask your question.
It looks like I'm off the hook.
Yeah, can you elaborate a little bit on the GATA3 thing? I mean, I'm trying to put it together in my own head and see how do I take it from you.
So GATA3 came out as a great marker for breast cancers, and it is considered a specific marker for breast and urothelial carcinoma. But increasingly, it's been popping up in other tumors. And paragangliomas happen to be one of the tumors that can actually show strong and diffuse staining for GATA3. So definitely a pitfall. And that's where my comment about ordering a panel of immunohistochemistry comes in. And I follow that rule in my practice throughout to have something that will stain positive for the entity that I think I am dealing with, and then something that will stain negative. And that's where it helps. help. But also the other thing that was fortunate for me is that this particular paraganglioma did not have the strong and diffuse staining for GATA3, because that would have definitely created problems. But in that situation, the negative P63 helped. And the other stain that I didn't show here is a low molecular weight cytokeratin CK903. So a lot of poorly differentiated urothelial carcinomas, if they are not picking up P63, if they're not picking up GATA3, then they will have some reactivity for CK903. So that's also can be thrown in that mix.
Thank you so much. Because on the low power architecture, I did consider a metastatic breast cancer because it can mimic so many other tumors. Yeah. And then I would have gone through the hole with the GATA3. Yeah. And I just wanted, thank you very much. Thank you so much. So, yeah.
So I'm trying to speak that. Have you seen any literature on FOX2B specific to paragangliomas in the bladder? Is it a good marker?
We don't have that stain. And this being my only paraganglioma case in the bladder tumor, I don't really have experience with that. Thank you.
Thank you again, Dr. Pense. Megha? So that's next, okay. So our next talk is on memorable liver cases. And again, one of those very intriguing subject. Dr. Saxena will be presenting those cases, and she's the professor of pathology and lab medicine director. She's liver pathology service director, GI and liver pathology fellowship at medical director, histology lab. She's currently practicing at Emory University. And we are ready to take on.
Good morning, everyone, and thank you for being here so bright and early. I'm not sure that I'm awake, actually, but I'll try to go through this case as fluently as I can, I guess. So this is a single case that I will be presenting, and it is a 50-year-old female who was having a cholecystectomy, and at that point, she was found to have splenomegaly. And because she had the splenomegaly, they imaged her liver, which was found to be enlarged. The spleen was 27 centimeters, and she was sent off to a hepatologist. And because they saw an enlarged liver and an enlarged spleen, they said, oh, maybe she has cirrhosis, and we should go ahead and do a liver biopsy to find out what's going on. And so I get a liver biopsy with this information, basically portal hypertension 3 times over and liver tissue. And this is the biopsy that I had. And you can see that these are very good cores of tissue. So thankfully, at least we have a very good liver biopsy. And even at this low power, you can see that there isn't a whole lot of blue. So it's not really inflamed. And it looks more or less, like it's normal, but we can't say that at that magnification. So let's look in, as we usually do, at the portal tracts. And if you look at these portal tracts, you find that they are not exactly normal, but quite normal in that they're not expanded. There is a little bit of lymphocytic inflammation in one of the portal tracts, maybe a few extra bile ducts. We don't have a pointer, we're just the mouse, right? Okay, let me see if I can do, okay. So I don't have a pointer, but you can see that there are, the portal tracts may be mildly expanded. There are a few extra bile ducts, but nothing really to write home about. And I'll show you another sampling of some of the other portal tracts that were in this liver biopsy. Again, not too much. There is maybe minimal changes, but not a whole lot going on. And then we start looking at the lobules, and the architecture looks pretty okay. The hepatocytes look like they're doing fine, but then in between you see these very large cells. Some of these have a smudgy nuclei, they're multinucleated, they're sitting in the sinusoids. And besides the large cells, you also have some small ones with very hyperchromatic nuclei. And these seem to be everywhere. So here is another field, and here we see some more of these very dark cells. Some of these are multinucleated. The one in the left lower hand corner, it looks like a megakaryocyte. So you see the cells. And this is a low power view just to show you that there was quite a bit of density of these cells. So there were the megakaryocytes, there were also these atypical cells lying around. And the other thing that I want you to notice is that there is no fibrosis, there is no architectural distortion, there is no nodularity. So the report that I issued, I said basically because it had come with a diagnose, rule out portal hypertension or whatever, I had to first address that issue. And so I said that there is no cirrhosis, there is no nodular regenerative hyperplasia, because those are the two commonest causes of portal that we can see in a liver biopsy with portal hypertension. And so I had to say that that's not what I see. And then what do I see? I see numerous megakaryocytes and atypical cells, so I said that. And then I said that this is suggestive of a myeloproliferative disorder or a bone marrow replacement by an infiltrative process. So the next thing that happens is that there is a bone marrow biopsy. And so now we have an expansive history with this bone marrow biopsy, which is really nice. It says that a patient with a history of splenomegaly and enlarged portal vein with no evidence of liver cirrhosis, who was found to have numerous megakaryocytes and atypical cells in a liver biopsy concerning for a myeloproliferative neoplasm. The patient has had mild leukocytosis with neutrophilia, eosinophilia, and basophilia, as well as mild anemia in the past, but the current CBC is within normal limits. The patient has not had erythrocytosis or thrombocytosis, LDH levels are not available, and the JAK2 BCR-ABL1 mutation has not been performed. And the bone marrow biopsy is now being performed to rule out a myeloproliferative disorder. And here is the bone marrow. As you can see, it's hypercellular. And you can also see the large clusters of megakaryocytes, and not all of them look like they're normal. So they're definitely abnormal, and the bone marrow is hypercellular. Here's another field at a slightly higher power, and once again you see that this is a hypercellular, slightly abnormal bone marrow with clusters of megakaryocytes. Here again, you're seeing clustering of these megakaryocytes, and these are not normal, these are sort of mononucleated, these are atypical, and they are clustering. And the reticulin stain shows an increase in the reticulin fibers. So here is one field, and this is a second field where once again you see the clustering of the megakaryocytes and you see the increase in reticulin. So the report that was signed out by my colleague, Dr. Zhang at Indiana University, he says that the sample is hypercellular. There is increase in the myelopoietic elements with full maturation. The megakaryopoiesis, he says, is increased with formation of clusters and aggregates, frequent dysplastic megakaryocytes, including small, hyperchromatic, and large multinucleated forms. The reticulin stain is diffusely increased, 3+, and he calls it a myeloproliferative neoplasm. And then they proceed to do some molecular testing in which it was negative for BCR-ABL fusion, meaning it's not CML, and the JAK2 mutation was positive. So a year later, this lady comes back because now she has this splenomegaly that's really bothering her. And the history that we get with this spleen is a 50-year-old female with a history of JAK2 positive MPN, myeloproliferative neoplasm, diagnosed a year earlier, and she now has massive splenomegaly. And so we have the spleen here. Basically, it was enlarged, and what I saw was extramedullary hematopoiesis. So you're seeing the megakaryocytes, some of which are definitely abnormal. Most of them are abnormal, actually. And then there's a little cluster of erythroid precursors in the middle of that field. Here is another slide, another field from the spleen, which also shows erythroid precursors or extramedullary hemopoiesis with erythroid precursors. So she was started on hydroxyurea because of a JAK2 mutation, because of her myeloproliferative neoplasms. At some point, she stopped taking it. 5 years later, she had 2% blast. She was offered bone marrow transplantation, which she declined. And my last follow-up with her was in late 2022, and she was alive. And I don't know about well, but she was alive. So hematopoiesis in the liver, that brings us to hematopoiesis in the liver. And what we know is that in fetal life, the liver plays a major role in hematopoiesis. It's the major site, and it's the major site of production of thrombopoietin and erythropoietin. In postnatal life, it sort of backs off a little bit, but it still has a major role to play. It's a major site of production for thrombopoietin. It's the main site, whereas it sort of gives away its role of producing erythropoietin to the kidney. So the kidney begins to do that. But it still stores iron, it stores vitamin B12, folate, it synthesizes transferrin, and it's responsible for degradation of red blood cells. As we know, it's one of those organs, it's part of the reticular endothelial system, if you will. So hematopoiesis in the liver, or extramedullary hemopoiesis in the liver looks like this. The portal tracts are massively expanded. You have all these cells. You also have cells out in the lobules. Most of these are erythroid precursors. And this is a biopsy from a neonate. And every one of us who has seen one of these for the first time in our lives, we see this. We see a case of neonatal cholestasis. We get a biopsy of neonatal cholestasis saying, is this neonatal hepatitis? Is this biliary atresia? We get one of these and we look at it and we say, oh yeah, this is neonatal hepatitis. But actually it's not. It just takes you that one slide, the first biopsy, to recognize that this is extramedullary hemopoiesis, quite normal in the neonate, and it should not be mistaken for neonatal hepatitis. So this is what it looks like in the neonatal liver. Not all of them, but quite a few of them that come for a diagnosis of neonatal hepatitis. So we just have to be careful about that one. And this is showing you the same thing on a little higher power, so that now you can appreciate the erythroid precursors as well as the myeloid precursors that we have here. And one of the clues is that you always see a lot of erythroid precursors. So if you see loads of eosinophils in a patient with neonatal hepatitis, probably extramedullary hemopoiesis. So what about hemopoietic cells in the liver? Well, megakaryocytes, if you're looking at liver biopsies, you're going to see those from time to time. Megakaryocytes in the liver biopsy are not uncommon. And they're not uncommon in the lung either. And on the right-hand side, you see a normalish lung biopsy with megakaryocytes. And these are just intrepid travelers. Megakaryocytes have itchy feet, right? They like to go around and look around, hey, what does the liver look like and what does the lung look like? So that's what they're doing. They're perfectly normal. They're just traveling through and having a little bit of a tourist experience, I guess. But and this is not necessarily related to what I'm saying, but as I was researching this talk, I came across this article, and I never knew that the lung actually plays a major role in the production and maturation of megakaryocytes, especially in infection. So who knew that? And I just thought I'd throw that in. But coming back to the liver, because the liver is a site of hematopoiesis, because you see megakaryocytes, I just said you can see them in normal liver biopsies, your next question is going to be, so when is it abnormal? When do you trigger a bone marrow or, something dangerous like that? So there is a paper that was done by my friend Isabel Fiel at Mount Sinai, and they looked at extramedullary hemopoiesis in liver biopsies. And they had 42 patients, mostly, not mostly, but a large proportion of them were female. and male. Median age is 50 years. And these biopsies were done for abnormal liver function tests, or they were operating and they just plucked off a little piece of liver, or for abnormal imaging. Half of these patients had splenomegaly, 40% had a hematologic disorder, and the other 60% did not have a hematologic disorder, but there was a whole a group of patients with viral hepatitis, autoimmune hepatitis, PSC, PBC, and things like that. So what they did was they tried to grade the amount of hematopoiesis, and they scored it from 0 to 3, depending on the number of foci that were present in the liver biopsies. And this is what they saw. So A are the non-hematologic disorders, and B are the hematologic disorders. And when you have hemopoiesis in non-hematologic disorders, it just happens to be less. So most of it is grade 2, and some of it might be grade 1 in about a quarter, most of it is grade 1, and some of it might be grade 2 in about a quarter number of patients. Whereas when there is extramedullary hematopoiesis in hematologic disorders, then there tends to be much more of it. So you see that the grade 3 is now 41%. So it just means that if you see a lot of it, you do have to raise the alarm of something happening in the bone marrow or there being a hematologic disorder. Now here's another paper which was from the Mayo Clinic, and they say it's in the absence of myeloproliferative neoplasms. They had a series of 309 patients. And this is their breakdown of the underlying etiology. And you see that a large amount of these are actually hematolymphoid diseases. I don't know why you would put acute myeloid leukemia there and still call it non-myeloproliferative, but maybe there's something I don't understand in hematology. But at the end of the day, these are mostly hematolymphoid malignancies that give rise to extramedullary hemopoiesis in the liver as well as in the spleen, but that's not what I was focusing on. So now, for a very, very brief overview of primary myelofibrosis, I know that it would be cruel to do this so early in the morning. It's cruel any time, but I'll just go over this very, very quickly. So this is the least common of the myeloproliferative disorders, primary myelofibrosis is. There is an equal gender predisposition, and it's a disease of older adults. It evolves from an early prefibrotic stage to a fibrotic stage, and the prefibrotic stage accounts for 30 to 50% of all cases. And basically, because we tend to diagnose things earlier and earlier, so that's why we're picking these up in the early prefibrotic stage. It is a clonal stem cell defect with abnormal megakaryocytes and granulocytes in the bone marrow. There is an overproduction of all those alphabets there, platelet, derived growth factor, beta, FGF, TGF-beta. And it is the non-neoplastic fibroblasts that deposit collagen in the bone marrow. And the bone marrow is now compromised, and so you have extramedullary hemopoiesis elsewhere. The other organs sort of chip in to produce red blood cells and white blood cells and megas. And in the peripheral blood, you get teardrop red blood cells. Now, the other thing that happens in primary myelofibrosis is that is an increase in angiogenesis in the bone marrow in the spleen, and they have measured increased levels of serum VEGF. And I am wondering whether the spleen that we had, the large splenomegaly, whether a lot of that was actually because there was a proliferation of blood vessels and the sinusoidal blood vessels in the spleen. I think that is what leads to splenomegaly. Personally, I haven't done any research or anything into that, but most of these patients do come with splenomegaly, almost 50%. There's a slide later that I'll show. And I wonder whether it is the angiogenesis that actually leads to the splenomegaly and not just extramedullary hemopoiesis. And karyotypic abnormalities are seen in 50% of the cases. There are 3 driver mutations that are known. The best survival is if you have the CALR mutation, and if you don't have any of these, then it means the shortest survival. The survival is not good. And there should be no BCR-ABL fusion, that means CML. 30% of these patients are asymptomatic, 70% are symptomatic. Most of the symptoms are generalized weakness, weight loss, low-grade fever. There might be things happening in the blood, in the peripheral blood, like leukocytosis, thrombocytosis, etc. They are prone to hemorrhagic episodes because your megakaryocytes are sort of dysfunctional. And splenomegaly, 90%, that's a hallmark. And like I was saying, it's probably because of the angiogenesis that goes on in this disease. And hepatomegaly is present in 50%. Now, diagnosis of primary myelofibrosis depends on major and minor criteria. Here they are. I'm not going to read them. They are in every textbook, I think. And then there is a prognostic score, which is a dynamic international prognostic scoring system. It depends upon 8 predictors, and the risk status is defined as low, intermediate, or high, depending upon how many of these risk predictors the patient has. It is the least favorable. So in general, it's the least favorable of all the myeloproliferative neoplasms. The patients can have leukemic transformation, thrombotic hemorrhagic complications, and of course infections, as happens with any disease where the bone marrow is compromised. The survival for pre-fibrotic stage is 10 to 15 years. So if you are diagnosed at that point, you can expect to live that long. If you're diagnosed later on, obviously you have 3 to 5, your survival is going to be shorter. So what's unique about this case? So there is obviously a publication, a very systematic publication that was done at Mount Sinai. And you know, what happened with their cases, though, is that it is important to note, they said, that the diagnosis of a hematological disorder was almost uniformly known prior to a liver biopsy. What's special about my case is that this patient was not diagnosed. So we actually triggered the diagnosis on the basis of a liver biopsy. And with that, I thank you for your attention.
Questions for Dr. Saxena? I have one silly question. And the question is, like, you know, in this day of like subspecialty and super subspecialty practices, how do you combine and how do you draw on your experience from liver pathology to bone marrow pathology, myelofibrosis? Any advice for the younger generation in our audience?
Well, I don't know if I have any advice, especially because our training standards are going one way. I won't say which way. But for me, for example, I had done HemePath in the past. I have done DermPath. My thesis was on DermPath, and we grew up with generalized surgical pathology, and then we specialized, right? So that was the advantage that we had. For the younger folks, I would say that when you are attending a conference, for example, or your department's going to have multiple conferences, right? Try to attend the others, not just yours. So, you know, you may be interested in GI, but go and look at what HemePath is doing. It's interesting. Go and look what DermPath is doing. It's interesting. You won't become an expert, but you will get a wider flavor of pathology, and you might even steal some ideas. So if they have a cool antibody or a ISH that they're doing in HemePath, see if you can apply it to your GI biopsy or your GYN biopsy. I think it always helps to, knowledge is never wasted, in other words. That's all I have to say, I guess.
Yeah, thank you very much for that. Okay, let's talk about patient safety. Memorable abdominal FNAs I've learned from, to be presented by Dr. Padmanabhan. And Dr. Padmanabhan is currently Professor and Director of Quality and Patient Safety at the Department of Pathology and Genomic Medicine at Houston Methodist Hospital. I welcome you.
Thank you so much. Thank you, Megha. Thank you, AIPNA. I started off as the editor of AIPNA and moved over to treasurer of AIPNA. Strongly recommend getting involved. It's been great. The way my talk is designed is I'll be speaking in two different parts. The first part is to give you some sort of a background about patient safety and why it's important, and then moving on to the cases. I'll go through my cases fast. So let's basically talk about all the oops and all the potential oops that we can get into. So you might have heard about To Err is Human, which came out, which is the Institute of Medicine, now of course renamed to the National Academy of Medicine. And this book brought about the public's attention to safety and how, quite 44,000 to 98,000 people die every year due to medical errors. And then this was followed by crossing the quality chasm and improving diagnosis in healthcare. Now, the issue with medical errors is these could have been prevented. That's the buzzword. And the most important thing is nobody comes into work to make an error, but a lot of times it's the system that you're working in, the environment that you're working in, that sort of is very fertile and allows an error to happen. Now, what's more chilling is how improving diagnosis in healthcare, there's a lot of focus on diagnostic errors currently. Most people will at least have one diagnostic error in their lifetime. And 5% of US adults who seek outpatient care will have diagnostic errors. And I'm sure each of you has some sort of experience with diagnostic errors or medication errors. I was at the pediatrician with my older daughter who's severely allergic to ampicillin. And guess what prescription she gets? Ampicillin. And I'm like, no. So things like that. Diagnostic errors happen all the time. I've seen it happen so many times with my own family. Now, the worry, the other side of this is that it is the leading type of paid medical malpractice claims. Regardless of what belief you ascribe to, or whether you believe any of this is true, it is considered it is in the forefront of patient safety today. And medical errors is thought to be the third leading cause of death in the United States. Now, how do you define a medical error? You might think, oh, it's just a mistake. I made a mistake. It could be something that was done because you didn't know, I didn't know. It could be negligence, where it depends on how your peers would have acted in the same situation. Did you do an action that caused the error, or did you do an inaction that caused the error? Both are important. Now, the Institute of Medicine defines medical error as failure of a planned action to be completed as intended, or use of a wrong plan to achieve an aim. Now, we may say that patient safety and quality are, it's just an issue of semantics. They're both, equally, they're both pretty much the same. Now, the important thing is you want to prevent accidental injury. That's what we are aiming to prevent out here. And you want to improve the desired health outcomes. Now, what about anatomic pathology? A lot of us here are pathologists, and so anatomic pathology is what I should be focusing on. Now, how do we define errors in anatomic pathology? There's been a lot written about it by Dr. Sirota, Dr. Nakle, Dr. Raab, and others. So it's very difficult to come up with one definition, right? But a major error is one which has major effect on therapy and or prognosis. While a minor error, we see typos all the time. We see a lot of things that could have, that have a minor effect, It's kind of hard because in today's categorization of, is it low grade, high grade, is it, there's so many nuances that go into classification of an error. So when we think about a test, the test cycle starts when the patient interacts with his primary care physician or, a specialist. which type of test is selected? Is the correct test selected? What about the requisition? Now, I don't know if you've gone into offices, the radiology suite and others, where you might actually find some other patient's requisition still sitting there, some other patient's label still sitting there. These are all potentials for error. Then the sample has to be collected. Is an adequate sample collected? Oh, the bane of the cytopathologist's life. Uh, then the sample has to be labeled. The label has to match with whatever the requisition is. It has to be transported. Your courier has to bring it all the way, or you could have, it could be piped in. It doesn't matter what system you use. It's still, open to some potential error. I don't know how many of you have walked into your central receiving, and if you do cytology, you will have to share your sample with microbiology, hematology, and cytology. I don't know how many of you have seen shared samples. You may get the 1 cc while micro gets the 10 and vice versa. That sample has to be logged in. The patient gets an entirely new number, once the sample gets logged in, because we still don't have a process where the sample gets logged in from the first time it's taken. There's a lot of steps that happen to the sample. Then, of course, we review it, your fellows review it. The sample has to be prepared before that, and there could be potential issues there. Then you review it, then you diagnose it, then you put your report in your computer, and then it goes off into the cyberspace, and then you have to hope that it reaches the correct person who ordered the test. Any of these issues can cause errors. Now, there's been most errors in pathology are pre-analytic. Now, this article came out from Boston, and this is about, this came out in Cancer Cytopathology, where they talked about pre-analytic errors, and this being the significant thing for patient safety. And they don't describe, they don't go into too many details about whether this was cytopath errors or general lab errors, but by far, most errors are pre-analytic before they come into the, before they come to us in path. However, there's a significant proportion which is analytic and post-analytic. Now that brings me to my cases. So the first case I have is a 26-year-old Hispanic male who has a liver lesion. Now I work in an academic center, so my fellow went and brought me the case. CT-guided FNA performed by radiology. It was done by a radiology resident, given to the cytology fellow who looked at it and said it's adequate. We have smears and a cell block that was performed. This is what the smear looks like. Large cells, abundant vacuolization. Some of the cells did show prominent nucleoli. This is another picture from another area of the smear, which looks like this. Again, it could be, these are polygonal cells. They could be hepatocytes. They look like hepatocytes. I was like, yeah, they look like hepatocytes. Thankfully, I also had a cell block. And the cell block was much better than my smears, I must say. And the cell block showed all these polygonal cells. And, when I see something like this, your first thought is it could be hepatocellular carcinoma. I have a lot of hepatologists, hepatopathologists sitting in this audience. So, but, that's one of the things you would seriously consider. Another area to show that, there was mitosis. Many of the cells did show prominent nucleoli and abundant cytoplasm. And, it does show thickening of the plates, and it does show, it does show some sort of a sinusoidal distribution outside those plates, right? So you're not wrong, and just another picture to show the same. So my fellow came with me with a differential diagnosis of hepatocellular carcinoma, classic type. It could be a fibrolamellar variant because he's only 26 years old. I don't know if I can rule out a metastatic renal cell carcinoma, was what she said. Okay, so what do? I have two GI pathologists sitting on either side of me in my office. I mean, I did think about it. I did think hepatocellular carcinoma very seriously. So I go to GI pathologist number A, and she's like, HCC, what's your problem? Sign it out. If you're not, I do cyto and GU. So, she also said, if you feel uncomfortable, I'll sign it out. It's a 2-minute case, All right, so that's one side. The second, much younger pathologist, no ageism here, who, fellowship trained, straight out of fellowship, who's like, Looks like classic HCC, but he's young. I'd be a little cautious. Do you know what the serum AFP is? What about, did you check, what immunos have you done? I was like, no, I haven't done immunos as of yet, but I'm planning to get some basic immunos. She said, I get immunos on all my cases. So I have two polar extremes here, all right? And I'm showing this to reiterate a point. So I did do immunos. My first line of immunos, hepa, arginase, CD10. I like CD10 because it shows a beautiful canalicular pattern. You could use CEA, but depends on which, CEA your batch your hospital's using. They could be potentially, it could give you, a lot of aberrant staining. Now, a fibrolamellar, it didn't look like classic fibrolamellar morphologically. It didn't have those voluminous cytoplasm, though there is abundant cytoplasm in this case. But CK7 and CD68, which can be positive in fibrolamellar, were negative. Serum AFP was not elevated. And at the same time, I had, second line of immunostains. Any thoughts? So at the same time, that's me, I also had a classic hepatocellular carcinoma on my desk. This was an older person, and it shows this beautiful, you can see the nice vascularity on the smears that on the left. Again, thickening of plates, which is a little difficult to, you have to imagine it a little bit, but you can still see it. And, morphologically, this one was classic, HEPA1 positive, CD10 showing a nice canalicular pattern, and so on and so forth. So this was an easy case, but it didn't look like my case to me. The fibrolamellar variant, another example, and this is just an example, it didn't look like that. It didn't look like classic renal cell carcinoma to me. So I asked my fellow, I said, what about the AFP? She's like, it's not elevated, So a lot of times when we are signing out in a fast pace, place, you have to log on to another system to get onto the patient chart. I don't know how many of you use Epic. You have to look through, scroll through, you waste a lot of time finding that one line that you're interested in, right? Bane of my life. So I looked up the patient history myself because, by at this time, my fellow had moved on to other cases, because we had so many challenging cases, but I could not. The real history is it's a 26-year-old man who presented with worsening epigastric pain, nausea and vomiting. He had fallen off a ladder and had a huge, what he called a blood ball on his thigh. So at this time, the whole team, the team that was looking after him was like, what do you think this is? We really need to have some sort of a prelim on him. The ultrasound of the thigh mass showed, that it was, it was very worrisome for malignancy. And he had widely metastatic disease at this point. So the FNA was much after. Now you may ask, why did the clinician not target the thigh mass? Because that's so easy to access. But most often what happens is they will target something that will prove that it is metastatic, because then, it's much easier for them to move the patient down, because you really want to show metastases. So remember, there are lots of things that look like sheep, okay? So once I read the history, I was like, man, could this be alveolar soft part sarcoma? Because his cytokeratins, I did a second round. All the cytokeratins were negative. HMB45 was negative. I couldn't, I wondered about PCOMA, but I didn't see any. I didn't see any fat or think angiomyolipoma. Could this be a malignant angiomyo? I couldn't think beyond a sarcoma. It definitely didn't look like a lymphoma to me. Even ALCL, sorry to all the hematopathologists in the audience. It did not look like a melanoma. Again, you should never say never for melanoma, right? But so HMB45 was negative, PAN-CK was negative. This is my brain stuck on this. So I did send it out. I didn't put the preliminary diagnosis because we don't have a way to sign out preliminary diagnosis in my system. So I told the clinician, and whatever I tell the clinician, I need to put in my report, I need to close the loop with whatever clinician I spoke to. So RT-PCR was positive. So final diagnosis was metastatic alveolar soft part sarcoma. Now, this is one of the rarest forms of sarcomas, and this is not something that you're expecting to see on a daily basis. And usually it comes as a painless lump, which is what our patient presented with. And in children, it can be in the head and neck. And TFE3 is positive by immunohistochemistry. Now, if you use only TFE3, you could go down the wrong path because TFE3 is positive in other things also, right? Like renal cell carcinoma, mid-translocation renal cell carcinoma will show you TFE3 positivity. Other tumors which could show a little bit of TFE3 staining is picomas. You could have it in hemangioendotheliomas, anything that, so you've got to be a little cautious with TFE, just using one thing. And we did a quick study to see how we are with, what's better for diagnosing liver masses. And we found that if you're worried about metastases, cytology for some reason does wonderfully as opposed to needle core biopsies in terms of false negative rates. But cytology was not that good in terms of false negatives for other types of hepatocellular carcinomas, especially well-differentiated hepatocellular carcinomas. And there has been a paradigm shift in the United States. Dr. Wong actually from Brigham published this a long time ago, how needle core biopsies were on the rise, and she had not seen a liver FNA or a breast FNA in a very long time. So it doesn't stop my clinicians from coming and telling me, I think this is a hepatic adenoma, or I think this is FNH. What do you think? And I'm stuck with these touch imprints. I'm like, hepatocytes present. What am I going to tell them? But it doesn't stop your clinicians. They have not changed their practice. So when we look at metastases to the liver, the SEER data just came out, and it's a catchment area for multiple organs in the portal vein drainage. So and unlike breast being the main site, now the primary site is actually lung, followed by pancreas. So why, I had two opposing views on the same case. Why do we do that? Because we all have cognitive bias, all of us. This is basically how we simplify matter in our brains, and we have to filter through using our own personal experiences and preferences. And this allows us to prioritize and process large amounts of information quickly. I too am, I too have cognitive bias. So we are all visual people, right? Now, every time I look at this, the picture, the figure on the right, the line always looks longer. But I have even measured it. They're both the same size, trust me. So let's look at the next slide very rapidly. What do you think? Most of you would have missed the second "the" in this, Paris in the spring, right? So because our brain moves so fast, and we also have all kinds of different biases when we're looking at things. We have anchoring biases, which, of course, Travelocity and Expedia and others cash on, because we're only looking at one thing, which is price. Many of us get focused on one thing, which is price. Confirmation bias, you think it's one thing and you will use 20 immunos to prove that it is that one thing, right? Overconfident, you're very, I know this is what it is, this is what I'm going to call it. And we have zero risk bias, because I have two extremes of GI pathologists I was working with. One was, I'm fairly confident this is HCC, and the other one is I would use 25 immunostains. Now, to all of you who use immunostains, I use them too, but use them cautiously, use them judiciously, because each stain is a test, and every test has a false positive and a false negative, every single test. So if you're using 25 immunostains, you are going to come up with some sort of aberrant staining, and you're going to be scratching your head wondering, what is that? Okay, nevertheless. So, let's move on to our second case, which is a 56-year-old woman with nausea and vomiting. And this is what, the FNA looked like. I thought it was really nice. It shows a lot of internuclear inclusions, but remember, hepatocellular carcinomas can show internuclear inclusions, can show prominent nucleoli, and will have pigment, but the pigment, we are now at the tinctorial properties of the pigment. Is the pigment dark? Is the pigment green, right? So to me, this looked like a melanoma, but then, you don't see melanoma in the liver every day, right? So you really want to see, where could this have come from? And I was walking down the hallway and the radiologist says, oh, by the way, that patient had a glass eye, So this lady actually had a history of uveal melanoma, and this was actually metastatic uveal melanoma, which does happen. And because the commonest tumors in the uvea are melanocytic, benign or malignant. And the interesting thing about metastatic uveal melanoma is these micromets sit in the liver for a long time and then can suddenly become clinically relevant, which is what happened. So in this case, we did do HMB45. You want to have at least 2 stains positive, and thankfully S100 was positive. We called it metastatic melanoma. So if the patient history is not fitting, if it is a young patient showing something potentially horrendous, I have now taken to looking up, logging on to Epic and looking up the patient history myself, regardless of how much time it takes me to do that. And if they don't match, stop your assembly line, investigate, or put that case aside, because even CAP is pretty generous. 80% of your cases need to be signed, not just CAP, but most of you, 80 to 90% of your cases need to be signed out within 48 hours. And it's okay if this is a complicated case. Take your time. Don't rush in and fall into a trap, because mistakes do happen. We are likely to make mistakes, let's put it that way. Breast removed by mistake, paperwork slip up blamed. So you have 2 breasts, one completely benign, one aggressive tumor. The woman with the benign breast was given the diagnosis of the aggressive malignancy. Now, unfortunately, there's 2 sides to this, actually more than 2 sides. The woman with the malignancy is walking around thinking she has she has no cancer. So you have those 2 extremes, and you have the poor pathologist who's sitting in the middle of this, wondering, oh my God, how did this happen? So errors happen. This is not a talk on medical errors, so I'm not going to go dive deep into this, but remember, errors do happen, and we are trying to prevent as many errors from happening. A lot of subspecialization. I know that, no pathologists it's very difficult for us to agree on a lot of things, and subspecialization versus not is another area which is very contentious. But one reason why a lot of litigation has come down in pathology is ascribed to subspecialization practices. So just keep that at the back of your mind. So, this is from Dr. Epstein, came out in the Wall Street Journal. 1.4% of PATH cases have serious errors, especially GU, is it low grade pancreatic, prostatic cancer? Is it high grade? Is there any grade 4 in it? Things like that. So they can get misdiagnosed. Okay, now let's move on to case 2 very fast. This is not a true FNA, but this was the second time acidic fluid tap in a 60-year-old woman. My tech had sent it in as negative for malignancy. The first one was also called negative for malignancy. Then I see cells like this, which frankly, honestly look like histiocytes. Can't blame anybody for thinking they're histiocytes. But I don't like that one cell which is sitting there with this indented nucleus. That makes me very nervous when I start seeing cells like this. When I see cells like this, that's a trigger for me to investigate. CD68 is negative. Cytokeratin is positive. This is not, and also CK20 is positive. Okay, so sometimes it may take 2 to 3 attempts to make a call. This was from the first tap. One of the things I did was to pull out the first tap just to make sure that I wasn't imagining something. And this is from the first tap, and this also had similar cells, large, voluminous, mucinous cytoplasm. Now, a lot of times things come to us in thin prep, right? Or we prepare thin prep, and you may lose the background, you may lose the mucinous quality to your slide. And this actually was a patient who had pseudomyxoma peritonei. Now, of course, you call it low grade or high grade. This looked pretty low grade, but it's basically a mucinous tumor, right? And it's not pseudomyxoma. It's not a myxoma, as you all know. And you could call it mucinous carcinoma peritonei if you want to, but most people still use the term pseudomyxoma peritonei. And so how do we pick out errors in pathology? One thing we do is secondary review or audit cases. It could be retrospective or prospective. We could do consecutive cases or selected cases. We do it at a clinician's request. Now remember, anytime a clinician asks you to review a case, that's where you are most likely to find an error, a serious error. The clinician may have sent prostate biopsies, somebody signs it out as negative, then the clinician says, oh, by the way, this patient is status post therapy with ADT and a whole range of radiotherapy, and then you go back to the case, get PIN4 on all your levels, or at least 1 or 2 of your levels. This didn't happen to me, but I have seen it happening. Or you might review cases for tumor board, and you pick up cases there. This patient did have pseudomyxomatoperitoneae. She had a borderline mucinous tumor of the ovary, which was subsequently picked up. Now, pulling out older cases is the scariest thing to me. Whenever somebody says, remember that case you signed out? I'm like, oh, what did I do? But that is something you need to do sometimes. You should let the clinician know, like if the older case was called negative and it is positive and your subsequent biopsies are negative, that older case needs to be corrected. You need to let your clinician know that there is cancer there or whatever. Unless it's going to change clinical management, it's okay if you don't change the diagnosis, but at least if it's going to change clinical management, make sure you do everything possible to do it right. So very quickly, case 3, nodule in the liver, 33-year-old man, touch imprints of needle core biopsies, a very, very cellular touch imprint. Normally you're searching for cells on touch imprints, but this one had so many cells. And you can see that the person who went on site for this case said it's adequate, it looks like RCC, it looks very low grade. Now, you don't have to give a diagnosis, okay? You can just say adequate or inadequate. But the PAP stains showed a very different picture. They showed this kind of an appearance with a lot of necrosis. Now, RCC can give you necrosis, no doubt about it. There were hardly any cells. But when you see so much necrosis and, we also had a good biopsy that matched with this. So of course, you're going to match your low-grade RCC with your biopsy, right? And this is what we had. We actually had Candida, and this is the biopsy, which shows abundant necrosis, which was picked up on the PAP stain. But the DIF-Quick actually did the touch of those areas, which showed abundant renal tubular epithelium for the most part. So the patient actually had a history of AML. Final diagnosis, of course, was negative for malignancy, necrotic material and fungal elements consistent with Candida. But what got to me on this case is somebody wrote, please correlate with culture studies. Culture studies were not taken. Okay, now whose job is it to take the culture studies? When you go for adequacy, should you tell them, take for culture, not take for culture? Is the radiology resident who's doing that case to take for culture? But in any event, there was an error, but thankfully it wasn't a terrible error because very quickly it got resolved. And no material was collected for culture studies. The other issue that I had with this case is that the discrepancy between the final and the prelim was not, nobody said a word about it, in the final report. If there is a discrepancy, if you've told your clinician something malignant and you're changing it to totally benign, let them know, so that they're not thinking that this is malignant. RCC can have many, many faces. And this was a case that I had 2 weeks ago, and I didn't realize that you could even have these basement membrane-like material in RCCs. And this was actually a clear cell renal cell carcinoma with basement membrane-like material. And you can see it in the next slide, that little glob. But it was really nice on my touch imprint that I quickly showed you. Last case 4, patient. So sometimes we get material in thin prep. We're not always asked to come to give on-site adequacy. And this was a 65-year-old female patient with a pancreatic mass, performed on 3 p.m. on Friday afternoon. Material was submitted in a thin prep vial. And of course, the history, as all my other histories, is rule out cancer. And this is what we had. We had these fairly pleomorphic cell clusters, had a lot of necrosis. And when I see necrosis, I get very nervous. And some more pleomorphic clusters. This was thankfully not my case, but I wanted to show it to you to reiterate a point. Some more, more of these, and the cell block also looks like this. So when you see something like this, you really are thinking malignancy, right? Or if they tell you it's a cystic mass, you're at least going to call it suspicious for malignancy. You're not going to call it negative. There were other areas in the thin prep which were really thick and difficult to see. This was signed out as positive for malignancy, and it was called adenocarcinoma. Now, many of us use drop-down lists, to your accessioners, go in and watch how they accession a case, to which clinician. This, unfortunately, went to a chiropractor, and Dr. Gorman, who's the gastroenterologist, never got the report. Dr. Gorman was away after doing the FNA, he left for vacation, came back 3 weeks later, didn't realize about this patient. And the patient comes back to the hospital without the initial report, which we have signed out, with the PATH department has signed out. Medical mistakes happen. They happen everywhere, right? Now, I don't know how many of you read Good Housekeeping. I wasn't ascribing to it, but I found this phenomenal article in Good Housekeeping. Good Housekeeping tips for the public. If your result is negative, if you don't hear back, don't assume it's negative. Call your doctor. Just because he hasn't phoned you, don't think it's negative. And there's a lot they say, and it's actually a phenomenal article about how to keep yourself safe as a patient. Now, what happens with post-analytic data handling of reporting and test results? Many places don't have a critical value policy, or if they have a policy, your pathologist may not know about that policy, right? Now, how could this have been prevented? If the person who signed out the case had called Dr. Gorman or Gordona's office, they may have realized that it's gone to the wrong person, right? Many places do have a list of critical values. Now, a lot of this is, again, there's a lot that's been written about this, but again, it's not written in stone, and many people say that it's more of an opinion that this is best practice, which makes it a little harder because it's not, when you're looking for hard data, it's not really hard data. So now if I find any malignancy, I tend to call my clinician, make sure that I close the loop on if they're not expecting a malignancy, or sometimes even for expected malignancy. I mean, depends, we see so many prostate core biopsies. I may not call the clinician, I may email them on some, but have a list. Now, this is the original paper which showed this high risk versus low risk, came out in the British journal, one of the British journals. It was regarding pharmaceutical errors. And they actually used a logarithmic scale, for health loss, a number of encounters. We are along with bungee jumping. So that's where we are. Commercial aviation, taking a train in Europe, nuclear power plants are all minimal risk. Now, I don't know how many of you watch TV, but then you hear this all the time, shocking the patient for an hour, gory scenes, somebody doing a C-section on the airplane. Makeshift medicine happens all the time. Instant out, you give the patient a shot and the patient's out. Stat, everything is stat. So, but thankfully, a lot of things which actually happen don't show up on TV. I leave you with that. Thank you.
Any questions for Dr. Padmanabhan? Yeah.
Thank you. Great talk, and we do see these errors and working. But you talk about reporting your errors too, because I see some of the younger pathologists, they have made an error in their prostate core diagnosis, and this is a real example. Sat on it for 6 months, went out, and consultation was different, and it was diagnosed malignant, they didn't let me know. So I think it's very important for everyone to understand that you make mistakes, and it's important to improve.
I totally agree with you on that, 100%. So when I was at WashU, we had a very transparent system. We would talk about errors in our GU consensus conference. And if any of us made an error, it was, told to the others, and we'd all look at the case together, to see, because hindsight is always 20/20, is that breast metastatic to the urinary bladder, or is it a bladder cancer? Sometimes those things can be difficult. Is it a prostate core biopsy which is completely negative, or do we need to get PIN 4? Those are issues. It all depends on the culture of the place you're at. I will not say more than that.
I have one question. I mean, in your role as the quality and the patient safety officer, is there a particular area of subspecialty area of anatomic pathology that you see more incidents than the others?
Ooh, good question. I have been tracking errors in AP, and I see it's not like errors don't happen. They do happen, and I've seen them with biopsies more often than resections, but I've also seen them with resections. Now one thing we should do is, if an error happens, what do you do after the error? Do you get in touch with the clinician, get in touch? Many of us are a little uncomfortable about getting in touch with the family. So, there's no mandate that you should, but what should you do if an error happens? Many places hide errors, which becomes really difficult because they don't want to talk about it. We used to do a root cause analysis on these errors, like why did this error happen and why, to try and understand what actually happened. A lot of these things take a long time, so they're not quick fixes. There is no quick fix, unfortunately. So I think it's very essential to have some sort of a follow-up. And we also used to track errors in terms of physicians, like a pathologist. Like one pathologist may be making more errors than the others. That person may actually need help. You can't just go up to somebody without data, right? So you need to have longitudinal data. Unfortunately, many places don't have longitudinal data. That becomes a bit of a problem to track errors and go back to the pathologist. It depends on where you practice. Okay, so yes, please.
So, I don't know, in your practice, do you put like an attention as malignant or alert? Do you put an alert stamp on malignant cases or if it's an FDA, things like that? I know it's controversial. Some people say they're spoon feeding the clinician and they will literally in their office take his reports and present it to alert versus non-alert reports.
So there is a very good article called Pathologists Are from Venus, Clinicians Are from Mars. I don't think they truly understand the nuances of a pathology report. And that has been clearly shown many, many times. And frankly, I wouldn't think about them as clinicians. What is the best thing for the patient? If you need to spoon feed your clinicians, spoon feed them. Just let them know this is what I mean. The terms I've heard as patient safety and quality officer is incredible. Oh, hide it in the micro. So many people put long micros and hide so many things there. For me, I personally don't like to use micros, okay? Because every word you say there is a potential for misinterpretation, or unless you are crystal clear. So if you can alert your clinician, we were trying to get an epic alert, like a heme case, or, a clinic chemistry case. If it's a malignant thing, it goes immediately so that they respond immediately. And the problem is, it's not just one clinician. There's a team that looks after the patient. And the alert needs to go out to all the team members. And if you're using just one system, if you're not using the the clinical information system, it may not go to the people who are actually with the patient. I'm all for alerts.
Thanks, Vijay. That was very nice. Just want to add something to the last thing you said about if clinician getting the report. Another layer to that is it's not unusual to get the radiologist being the one doing the bouncing, and the radiologist that has the name attached to the report. So when you sign it out, it goes to the radiologist who never reads it. Right? So in Minneapolis, what we do, we have this, I don't think it's written, but we all have this thing that when you sign out something that was labeled brush originally, you have to document in your report who you spoke with. And so in that process, sometimes you realize that the person you call is a radiologist, because they will tell you, oh, I just did the biopsy. Sometimes it takes a lot of time to find the right clinician, especially for those of us who work with transplant. You don't want to go at Friday 5 p.m. without letting somebody know what to find. So we have that. It has to be on the report that I spoke with so and so person. And now we get the fellows who actually do the calling so that they can get the message of what they need to do. And then the other thing about the microscopic report, I don't know whose idea it is to put microscopic section at the very, very last page. I never use it because it's useless. Nobody is patient enough to read all your report on the page. So everything is important. And I do live one, so microscopic description is part of my life. So everything goes into the comment. Right? So diagnosis, comment, if you stop there, you get everything. So yeah, we have to spoon feed the clinicians once in a while, because that's the best way for the patient to get it right.
Thank you. Very, very valid points. I can't tell you how many times I have sent reports to the radiologist because I'm new to a new place. I don't know who the clinicians are. So nowadays I just send it through Epic Chat. I mass send it. I'm like, anybody who's related to this patient, here's your report. I don't know what else to do. I don't know who's the radiologist. I don't know who's the clinician treating. I don't know who's the, I don't know. So everybody gets the report. Sorry, but that's what I've started doing.
Thank you all very much. We are right on time. A big round of applause for all the speakers.
Thank you, guys.
Thank you all for coming at this early hour. There are savories outside in goodie bags. There's Wagh Bakri chai. There's that's my favorite brand, and I don't get any money for that. And there's chiuda and there's bhakarwadi, and so I know we who are from India sort of miss the spicy food here. So something. So please take your goodie bags. And I just want to acknowledge some people here. Ritu Nair, if you can stand up, please. She's running for Board of Governors. Everyone knows Ritu, but please make sure you vote and have your colleagues vote. Participation is key. And sometimes a good candidate because of lack of participation on our part, may suffer. So keep that in mind. And Ritu, you want to say a few words? Please come here. Please, we want to hear you. Come. So this is a Zoom meeting that is being recorded to everyone offline also. Yeah, you can come here on the podium. People want to see you too.
Thank you, Megha. Good morning, everyone. I guess I just want to say that, like all of you, I love pathology. I love what we do, and giving back to the profession and trying to, make a positive change has always been something that has personally been a big part of my life. And I would like to continue doing that with the CAP now that I'm finishing some of my other responsibilities in other organizations. And what would I like to bring? I think just, so many things are changing. We've heard wonderful talks this morning, and I think from that you'll realize that medicine, healthcare, and our own profession, like everything else, is changing so rapidly and involves so many things that we've been hearing at this meeting that we know are going on. Our scope of practice, our ability to keep up with, the change and be continuously educate ourselves, be careful of mistakes, and just be part of, I think, making sure that pathologists remain relevant and ready for the challenges that practice brings to us, that we give our trainees, our younger generation, the next generation, the right kind of guidance and ability to actually take on the important, I would say, really critical challenge of being a pathologist who functions well in a multidisciplinary setting and who's armed with the knowledge and the power to be a critical part of patient care. So I think that's all of our jobs, and I hope to represent you and our profession wherever I can. And there's lots of wonderful, talented people who love our profession, just like I do, all of you do. So, in whatever capacity, whether it's a governor or just a pathologist who's active nationally and internationally, it's been a privilege to have been part of a lot of the society's leaderships. I've been involved since I was a second-year resident when I started as chair of the resident physician section when CAP and ASCP were one. Some of you in the room are my generation and remember that. We've fragmented, and I'm actually one of Dr. Karcher's residents. He trained me at GW when I was a resident, and I think the theme that he's presented for this meeting one CAP, one world is an important one, because our specialty has many subspecialties, and we're fragmented, but we have to remember the bigger picture, and that we're one profession and we're one people, and we come from with different talents and different backgrounds, and everyone's opinion, everyone's contributions are important. So I hope I have your support and trying to carry on the work on behalf of all of us, to continue to make sure that we, our profession, and all of us remain an essential part of patient care as things evolve. So thank you very much.
So those of you who are cytopathologists, and I do practice and pap smears and what's going on. So if we want someone as a board of governors steering our ship, it is Ritu Nair. A big hand for Ritu. In changing cytology times, I know there is I want to recognize some AIPNA members of the executive committee who are here. Viju is also our treasurer. Viju, could you stand up, please? Anand Lagu is one of the Sutradars, and the EC, as Bakul Dalal likes to say. And there was Neha, I think she left. There she is behind. She is a Twitter feed and very important person. And so a lot of people make AIPNA what it is. There are newsletter editors. There is the CME committee chair to be, Romil Saxena. So she's very hopefully successfully applied for a companion meeting status for AIPNA at the next ASCAP, and I'm sure we're going to get it. And so those of you, I know there's a fire chat on visa waivers. So being part of AIPNA to the residents and the younger folks is important to be there, because we as established members who've been here 30, 40 years want to do our best for the young incoming residents. And people come saying, oh, I have a J1 waiver job. And there are, I know, some people who want a J1 waiver job. So how to make those connections? So AIPNA will help that. Those who are doing J1 waiver jobs in Timbuktu or Nebraska, so nothing against Nebraska, but who want to move to New York or some other place, we have our connections. And we have so many people come and say, I have 2 jobs in New York. Do you recommend? Do you know someone? And so our newsletter will connect you guys. So please write to us in our newsletter, and we'll get the word out. And so it's like making the marriage between someone who wants A and someone who has to offer A. AIPNA is an organization, nonprofit. It's not restricted to Indians. It's anyone who wants to contribute to the world of pathology and lab services worldwide is at heart a member of AIPNA. So we do a lot of conferences. We've done them in South Africa. We've done them in Jordan. Next one is in Cancun. So please get involved to the younger generation. And those who are offline, and thank you for joining us. I hope you enjoyed the meeting. And again, thanks for coming and staying. I know there are many courses you have to go to. Please renew your memberships. AIPNA needs funds. So if you can afford it, a 10-year membership of $600 for those who are established would be very, very welcome. It's a nonprofit. If you want to make a donation, even if you're a life member, it's a 501c3 nonprofit organization. You'll get the receipt immediately. And please donate, because we are expanding our footprint. And all these meetings are very costly at ASCAP, ASCP. And we want to be in a position where we can give some remuneration to the speakers, who are world-class speakers. And we want to bring other speakers in, and an organization just to have the website, to run it. The work behind the scenes needs cash. And though it's a voluntary organization and all of us give of ourselves and our time, it's nice to have an organization that can sustain itself. And we made the decision that membership for all residents, fellows, anyone who's applying for residency can be a free member of AIPNA. So please tell your colleagues, it'll help them network with us. And there are many long-standing members here, members of the HOD steering committee, and do get involved in CAP, like Ritu is. Get involved, let your voice be heard. I see Bharti Zaveri got Pathologist of the Year award. She is an IMG just like us from Mumbai. And then there's the younger generation that also, Manoj also got an award. So many people got awards, and big congratulations to all of you. And thank you again for coming.
Big round of applause for making
My heart was full seeing the whole big room and people listening, and the talks went well. So every CAP will be, next one is in 2023. I want to shout out to that we want younger members coming up, like Avani Pensi. So anyone who wants to give a talk at next CAP'24, and please get in touch with me. And we want new faces. We want to hand over the baton to the younger generation, like Neha over there. And so please suggest speakers, and tell your residents we are here to help you with your waiver jobs, or whatever. Also, there are some jobs available for pathologists in India who have their MD. And Dr. Kohli was saying in Augusta, they can come for a Surge Path Fellowship. So, and it's a paid Surge Path Fellowship. So if you have friends back home who have an MD pathology and want to get 1 year of training here, those opportunities are opening up. But the only way we can spread this news, I talked to Sangeeta Desai from Tata Memorial, and she didn't know about this, that this would be available to her residents. So please spread the word, and we'll get all this out in the newsletter. Now in a digital age, it's easy to communicate, but you have to be part of that network. And I tell you what has made me so happy, I'm a social person, is making friends through AIPNA, lifelong friends. I wouldn't know Dr. Vijaya Reddy or Ritu Nair or Romil or Viju if we didn't have AIPNA. And I want that for the younger generation to have this close network of buddies. And we have a lot of young people in the AIPNA executive committee. So thank you again, and thanks for being here so early.